A very good afternoon to all of you and welcome to the GMOA Academic Hour program. So today's lecture is on diagnosis of bronchial asthma. It is my pleasure to introduce today's lecturer, Dr. Ganganath Gunathilaka, who is the consultant in Pediatric Respiratory Medicine. Dr. Gunathilaka graduated with his MBBS from the University of Peradeniya and went on to obtain his MD in Paediatrics from the PGIM Colombo. He was selected for advanced training in pediatric respiratory medicine, during which he gained overseas experience at the All Indian Institute of Medical Sciences in New Delhi and the prestigious Royal Brompton Hospital in London, UK. He has also successfully completed both the European Diploma and APPS Diploma in Pediatric Respiratory Medicine, and especially he is the first Sri Lankan specialist to be board certified in this field. So at present, Dr. Gunathilaka serves as a consultant pediatric respiratory medicine at the LRH Colombo as well as the National Hospital Galle. So let me warmly welcome Dr. Ganganath Gunathilaka for the lecture today. Over to you, Dr. Ganganath.
Good afternoon. First of all, I would like to thank Academic Committee of GMOA for inviting me for this lecture. Today I am going to discuss about diagnosis of asthma in children from clinicals to pulmonary function test. It is very important topic and hot topic for today. And before proceeding further, I would like to discuss what is this wheeze is. It is wheezing is a high-pitched musical sound. It is emitting from chest during expiration, resulting in narrowing of interthoracic airway. It is from interthoracic airway. It is during expiration. There could be inspiratory wheeze as well, but there should be expiratory component. This is due to expiratory flow limitation. And to generate this wheeze, there should be adequate airflow. Otherwise, we can't have proper airflow. Then we can't have any sound. How we can qualify this wheeze? This wheeze actually it is. Therefore, it is not very good, get a good source to get this proper this thing. But if we have documented source or documented report from physician or pediatrician, then we can get this as a good, reliable source. But there may be there may be some problem with the difference between severity in this documentation, but the reliability is good. In other hand, if there is doubtful cases, we can actually if there are doubtful cases, if there is no very severe attacks, or is at present if child is asymptomatic, and if the child is not having any life-threatening or severe attacks, we can wait till the child gets symptoms. If the child gets symptoms, then we can examine the child and we can see whether it is wheeze or not. Actually, we can't talk about wheezing or airflow limitation without talking about this Poiseuille's law. Actually, you know this Poiseuille's law. Actually, it is diameter of the airway or the caliber of the airway, and actually this diameter is inversely proportional to the resistance. It is not the ones, but it is actually fourth power of radius. If we can increase the diameter by 2 times, the resistance go down by 16 times. It is fourth power of radius. Actually, then in the same way, if there is a reduction of the diameter by 2 times, we can get this diameter to the half, then resistance will go up by 16 times. It's very important to know this Poiseuille's law to proceed. Actually, this narrowing could be due to several reasons. One thing is bronchospasms. Any bronchospasm can cause this wheezing or narrowing, and at the same time there is mucosal muscle hypertrophy. Also can cause reduction of the lumina, and then we can have wheezing. Then we can have secretions. They can obstruct this lumina of the airway, then reduce the airway diameter, and that can cause narrowing and wheezing. And the other, in the same time, there is constricted or obliterated airway, then narrowed airway, then narrowing is there, then there can be limitation. Then there are several causes to have this wheezing in children. Actually, infection is very important source, and viral infection, many viruses can cause this wheezing. And then the atypical infection and some bacterial and tuberculosis also can cause this wheezing. At the same time, there are other causes like mucociliary clearance disorder. Then there are cystic fibrosis, pulmonary dyskinesia, and bronchiectasis. They can cause reduction because of the secretion. They can reduce the lumina of the airway. That can cause wheezing. Then we have aspiration syndromes. Then we can have gastroesophageal reflux disease and laryngeal dysfunctions. They can cause more aspiration and can cause wheezing. And at the same time, there are anatomical problems at central airways, that airway malasias, laryngomalacia, tracheomalacia, or there can be fistulas, tracheocerebral fistula, laryngeal cleft. They can have central airway problems, ultimately result in wheezing. Then intrinsic airway abnormalities like foreign bodies or bronchial or lung cysts and sequestration, those can have intrinsic airway anomalies, and extrinsic airway anomalies from vascular ring or compression from the outside from any esophageal and foreign bodies, and mediastinal lymphadenopathy, like any extrinsic compression can cause then pressure onto the airway and can have narrowing. Then those are the causes in children who can get wheezing other than asthma. Asthma also can have reduction of the lumina of the airway, that is characterized by chronic inflammation and airway hyperresponsiveness, and as well as obstruction, reversible obstruction. Then that is characterized by these physical signs or these features can have this is bronchial asthma. Then asthma has many components. You can have this pictures chart. Then this is actually normal airway can have smooth. This is smooth muscles, and then have epithelium, and you can have a normal lumina. But in asthmatic airway, because of this smooth muscle constriction, you have reduction of the airway diameter. Internal diameter is reduced. Then narrowed airway because of this smooth muscle constriction. At the same time, you have muscle hypertrophy. That mucosal hypertrophy. Then have, because of this mucosal hypertrophy, this is smooth muscle. It is there, but there is significant increment of mucosal diameter. Then we can have narrowed airway because of this mucosal hypertrophy. At the same time, you can have more secretion and shedding. This is actually because of this secretion also we can have narrowed airway. Because of these features, we can have asthmatic symptoms. And in diagnosis of asthma, actually we have several components. In the to clinical evaluation, we have the certain diagnosis. Then we have identify comorbid conditions. Then we have to think about alternative diagnosis, other diagnosis. We have to think about these things, and we have to grade the severity. Then we have to identify triggering factors. Then we have to ask about recurrent cough, recurrent wheeze, whether it is coming in recurrence, then recurrent breathlessness, and in between attacks, this child should be normal. but we have recurrent cough, recurrent wheeze, and recurrent breathlessness. And as well as these children in rest, they can be normal, but they can have cough or wheezing during activities or stress, crying, laughing. These conditions they can have cough or wheeze, and as a activity exercises they can have wheeze and cough. Otherwise, they are normal. Then that is maybe a symptom of asthma. Then these children may be normal during daytime, but nocturnal cough will be there. Then again, you can see that there is normal. Their child can be normal in daytime, and there can be nocturnal cough. Then tightness of chest. These are symptoms of airway obstruction. To qualify asthma, we can to show that there are recurrent episodes. Then, as I mentioned in previous slide, there should be recurrent episode in between attacks. Child should be normal, and at the same time, if there is afebrile episode, then there can be febrile episode, but there should be afebrile episodes. Then, if a febrile episode, we have to think about viral wheezing and other things. But afebrile episode, then we have to think about asthma as well. Then if there is personal atopic, personal history of allergic rhinitis, other eczema like atopic features, and the same time family history of atopy also suggestive of this could be asthma. Then other thing is nocturnal exacerbation. Then nocturnal exacerbation, the daytime there can be symptoms, so there can be normal, but there is exacerbation during night. At the same time, there are stress or activity induced symptoms, and it's a trigger induced symptoms, like if there is any trigger or any exposure to dust or something, then if child get wheezing attacks, then it could be asthma. Then there can be seasonal exacerbations as well as in seasonal exacerbations, and the same time, if the child is the mother or father or parents, if they complain that his child is getting relieved by bronchodilators or nebulizations or giving oral steroid, then it is suggestive of asthma. And at the same time, we have to look for the examination. We have to see the signs of airflow obstruction. It should be generalized wheeze. The both sides we have to have this wheezing or prolonged exhalation, or can be air chest hyperinflation. They both sides there should be hyperinflation. Then there are signs of obstruction. At the same time, there are features of other atopy like atopic dermatitis or eczema. Then allergic rhinitis. Those features could be there in this patient. At the same time, this child could be normal during examination if there is in between attacks. In attacks, this child could be normal because completely normal during examination. Then after getting into the diagnosis, we have to assess for or identify comorbid conditions. Then allergic rhinitis is one of the important reason or important comorbid condition. We have to ask for wheezing and blocked nose. Those things we have to ask. Then adenoidal hypertrophy, again another comorbid condition that is important. That's blocked nose, snoring. Those things we have to ask. Mouth breathing, these are very important. And then reflux disease. Actually, we have to ask for gastroesophageal reflux, vomiting. Then those things important. And at the same time, now we have to think about obesity. Now these children are getting more carbohydrates and those diet and get more obese, and that obesity may confound this condition. Then we have to look for any signs of allergic rhinitis like mucosal edema, nasal mucosal edema, and post-nasal drip, and the same time cobblestone appearance of the pharynx. Those things are important during examination. And also we have to see about adenoidal hypertrophy, the large tonsils, and as well as adenoidal paces during examination. These are very important physical signs. And after getting into diagnosis, we have to think about other alternative diagnoses as well. In small children less than 6 months oldest, we have to think about viral induced wheeze, and as well as congenital heart disease, congenital abnormalities, congenital airway anomalies. Those things we have to see when child is very young. Then if there is localizing signs like unequal airway entry or any unequal physical signs, then in those situations we have to think about foreign bodies or congenital anomalies. Then other the condition like persistent symptoms, we have to consider many things, including foreign body, tuberculosis, and other bronchiectasis. Those things we have to think about this persistent respiratory symptom, because I have already mentioned in previous in diagnosis. Actually, in between attacks, child should be normal. Then child get attacked, and then after treatment, completely normal. Then we get another attack. In between attacks, child should be normal. Then if there is persistent symptoms, we have to think about alternative diagnosis. Then there should be unusual physical signs or clinical features like failure trial. It is not compatible with asthma. We have to think about other malabsorption like conditions. Then if there is multifocal infection, we have to think about immune deficiencies. Then finger clubbing, it is not compatible with asthma. Then we have to think about other alternative diagnosis like bronchiectasis or other things, and also congenital cyanotic heart diseases as well, and other clubbing in other lung diseases, especially in bronchiectasis involving the bronchiectasis. Then if there are consanguinity or these things, we have to think about immune deficiencies, cystic fibrosis, and as well as primary ciliary dyskinesia. These things we have to think about in alternative diagnosis. In asthma is a clinical diagnosis. We can diagnose asthma with a typical history, and we have to do investigation to actually rule out alternative diagnosis. But at the same time, in full blood count, if it is eosinophilia, it is compatible with asthma. In chest X-ray, it is usually normal in bronchial asthma, but there can be hyperinflated chest X-rays as well. Then bronchodilator reversibility, again a predictor. But otherwise, to diagnose bronchial asthma, we don't need investigations. But to diagnose or rule out other alternative diagnosis, we have to have investigations. But this is bronchial asthma is a initial in early days. It is just a diagnosis, but it is not just a diagnosis. Actually, like arthritis, like anemia, it is actually umbrella term for a lot of conditions. That in arthritis, actually, it is there can be rheumatoid arthritis, osteoarthritis, like many conditions. Like anemia, you have many anemia conditions like likewise in bronchial asthma also, it is not a single disease. It is actually umbrella term. When we diagnose asthma, there can be different type of asthma. Like in phenotypically, it could be Th2 asthma or non Th2 asthma. Like likewise, we have to have. Sorry for technical issues. Then we'll proceed from here. Then in asthma, actually, after diagnosis of asthma, it is just bronchial asthma is just a diagnosis, but it is an umbrella term. We can have different kind of asthmas. Then it is basically it can be phenotypically can be divide Th2 asthma or non-Th2 asthma. That this is then we can different kind of asthmas. Just it is not just a simple diagnosis. There are conditions these conditions of asthma. It is actually this could be asthma syndrome like. Then because of that we can have some investigation to see about these things as well. Then we can do one thing is spirometry. It is a basic diagnostic tool, and actually then it is, and then peak flow test and pheno and allergy testing. I will discussing these things in next few slide. Then when you have spirometry, it is actually we can do spirometry when diagnosis is in doubt, or especially in older children. Then peak flow test, and it is basically for used for monitoring of the disease, and pheno and allergy testing I will discuss in next few slides. In pulmonary function test, especially spirometry, it is a good good test, or it can be simple good test to do in children with asthma. Actually, in children it is particularly difficult, especially in small children less than 6-year-olds. It is a bit difficult to do this test because it is effort dependent test. And actually negative test is not ruled out in asthma, but positive test it is confirmed the diagnosis. Actually it is help to convince parents to improve compliance, because we can show them the picture and show them the test results, and we can improve compliance of these children. Then actually it is we can use this for progression of to monitor the progression of the disease. Then it is very important to this investigation. Actually in after GINA 2018, after that the GINA recommend to do this spirometry in all children when we come and say long-term treatment. But if child is very young, it is very difficult to do this test. But older children, we can do this test. Actually, it is a pulmonary function is a post, and we do the spirometry. It is post expiratory maneuver. It is we have to have good cooperation. If we can, child is more than 5-year-old, we can try this test, and if we can see several results. Actually, it is FPV1 to FPC ratio. It is less than 80. It is suggestive of bronchoconstriction, but is more than 80. It is normal, and we can see the bronchodilator reversibility. If it is more, if we can demonstrate FP1 increment more than 12% from pre-bronchodilator value to post-bronchodilator value, more than 12% increment. It is suggestive of bronchial asthma. Actually, we have to do several times. Actually, 3 acceptable results we have to get. This it should be repeatable. It should be repeatable. Then we can get largest FPC and largest FEV1 to interpret these results. Then again, this FEV1 ratio, it is if it is FEV1 to FPC ratio is, if it is low, we have to suggest we have to take this obstructive type of airway diseases. If normal, we can check FPC. It is normal. It is normal study. But if it is FPC to FEV1 to FPC ratio, it is less than 80%. Then we have to think about obstructive airway disease. Then they check the FPC. If it is normal, it is pure obstruction. When we can do the bronchodilator reversible test. Then if it is reversible, it is asthma. It is not reversible, we can think about other COPD or BOO, like bronchiolitis obliterans in children. Then if it is reversible, we can diagnose asthma. Then if it is FPV1 to FPC is low, below 80%, it could be combined disease with restrictive and obstructive. But in conditions where severe obstruction, we can have lower FPC. Both FPC and FEV1 will increase when there is bronchodilation, and can be even after treatment it can be normal. This is again flow volume loop of spirometry, you can see this scooping in this one. When there is obstruction, we can have concave and scooping in this test. It's very important to, this is normal test. You can see there is no scooping here in the respiratory limb. Then here, that is in here there is significant scooping. Here again, you to understand, this is normal one. Is light green one is normal one. This blue one, it is obstruction. Then you can see there is significant scooping. Then you can see you can demonstrate obstruction in this picture. Then if we peak respiratory flow rate, it is again important test, and usually it is a limited role in the diagnosis, but in monitoring purposes it is very important. You can have you can even do it in even at their home. Then we can tell them that if there is green, you can continue the same medication. If it is a normal value, it is green. Then if it is yellow stone, this causes, then they can have exacerbation. You have to come and meet the doctor. And if there are red again, it is very significant. Then we have to come to the even A&E as soon as possible. Then if you have this thing, we can guide them the treatment. PHENO, actually fractional exhale nitric oxide. Actually, it is a non-invasive method of detecting airway inflammation. When there is significant eosinophilic airway inflammation, we can have higher PHENO value. Then we can have higher. We can demonstrate increased eosinophilic inflammation by detecting higher PHENO test. By doing this, it is again very simple test, and but very informative. Then in asthma, it is actually you can see it is more higher PHENO value, that is parts per billion. If in children, if it is more than 35, or in adults it is more than 50, it is diagnostic of asthma, and as well as it can use as prognostic and predictive tool. And if it's there is continue to have higher PHENO value, there is poor control. And at the same time, as we mentioned, that is in detecting this PHENO and higher PHENO, that means it is in children usually Th2 type of asthma.
Fractional exhaled nitric oxide, or PHENO for short, is the small level of nitric oxide that your body breathes out, which can be measured to aid in management and diagnosis of asthma. Your body produces nitric oxide, or NO, naturally to combat inflammation, and airway inflammation is a central process in asthma and other lung diseases. Therefore, PHENO can be used as a non-invasive biomarker of airway inflammation to help differentiate between allergic and non-allergic asthma, as well as between asthma and other respiratory conditions. The 𝗦𝗨𝗧, a handheld PHENO monitor, which is recommended by NICE and conform to ATS and ERS guidelines. The 𝗦𝗨𝗧 makes PHENO monitoring quick and easy, plus it's completely non-invasive, with the ability to monitor airway inflammation in both adult and child patients. Furthermore, the ambient monitoring mode enables you to check ambient levels of NO. The 𝗦𝗨𝗧 has an inbuilt demonstration video of the breath test process. We recommend watching this video prior to using the device for the first time. This demo can be used to explain to patients how the test will run prior to performing one. The demo video can be accessed from the home screen by pressing the Play Demo icon. Select either the adult or child breath test icon and a demonstration will begin at an accelerated speed. Press the home icon at any time to exit the demonstration mode. The 𝗦𝗏𝗕𝗦 is capable of storing up to 50 patient profiles. From the home screen, press the Profiles icon to access the list of patient profiles. If you have not entered your PIN in the last 30 minutes, you will be asked to enter it before you can access this list. Select the patient you wish to view. From a patient's profile, you can view a graph of results, take a new breath test, or delete their profile. To create a new profile, choose an empty profile slot and use the keypad to enter a name or reference. Then press the Save icon to save the new profile. To edit a patient's profile, select them from the list and then select their name again. Use the keypad to edit the profile and press the Save icon to keep the changes or the back arrow to cancel. To delete a patient's profile, select them from the list and, once in their profile, press the red X. Press the tick to confirm that you wish to delete the patient, or the back arrow to cancel. Press Home to return to the main screen. To take a breath test, click on either the adult or child icon and attach a new mouthpiece to the unit. If needed, the test can be cancelled at any point by clicking the home icon. Take a deep breath, and when the exhale icon appears, keep the monitor upright and blow gently into the mouthpiece, making sure you do not cover the vent holes. The on-screen flow meter will guide you on the exhalation rate. Continue blowing until the green tick appears on screen to signify a successful test. If you blow outside of the exhalation guidelines, the test will beep, signifying a fail, and a red cross will appear. Either press the retry icon to take the test again, or the next icon to view the results anyway. You can press the home icon to return to the main screen, or you can save this result by pressing the save icon. If you choose to save your results, you'll be asked to enter your PIN if you haven't entered it in the last 30 minutes. Select a profile from the list to add your result to, or select an empty slot to set a new one. Readings and results can be interpreted using the 𝗦𝗏𝗕𝗦 interpretation chart. Each device will automatically be preset to the PIN code 0000. It is highly recommended that you change this PIN to a 4-digit number that you will remember. To change the PIN, press the PIN change icon from the settings menu and you will be prompted to enter the current PIN. Enter your 4-digit code and press Next to continue. Enter a new 4-digit PIN and press Next to continue. Re-enter your PIN to confirm the new 4-digit code and press the tick to save. If at any point you change your mind, press the back arrow to return to the previous screen or the home icon to return to the main screen. The 𝗦𝗏𝗕𝗦 monitor comes with a dock and charging cable to keep your monitor at hand and fully charged. To charge the 𝗦𝗏𝗓, first make sure that the docking station is connected to the mains using the charging cable provided. When it is receiving power, the green LED will light up and you may place your 𝗦𝗏𝗓 in the dock to charge it. The 𝗦𝗏𝗕𝗦 monitor comes with free patient management software, PhenoChart, allowing you to keep patient profiles, capture live readings, plot graphs, print reports, and much more.
And in we can do a skin prick test. Then to detect allergen, this very simple test, and we can do in skin, and we can use this histamine and saline for control, then we can use this different kind of allergen like house dust mite and other dust. Those things we can use, and pollen we can use to test this whether they are allergic to these things. And after doing this, about 20 minutes we can get the results. It is very simple. It's just this very minimal invasive test.
Hi, I'm Naomi. I'm a respiratory nurse specialist at Asthma and Lung UK. I'm going to tell you how to use a peak flow meter. When you first get a peak flow meter, ask your GP, asthma nurse or pharmacist to show you how to use it and how to take a reading. If you're checking your peak flow at home, you need to take your peak flow at least twice a day, every day, to get a useful pattern of results. Try to check it at the same time every morning and every evening. You need to use your best effort every time you blow into the meter, so you're comparing like with like, and you should use the same peak flow meter every time. Take these steps to make sure you use your peak flow meter correctly. Pull the counter, the red arrow, back as far as it will go to the top near the mouthpiece. Stand or sit upright. Choose what's most comfortable for you and always do it that way. Then take the deepest breath you can and make sure your mouth makes a tight seal around the mouthpiece. Then blow as hard and as fast as you possibly can into the meter, like this. Write down your score, which is the number next to the pointer. Do this 3 times in a row with a short rest in between so that you get 3 scores. All 3 readings should be roughly the same, but don't worry too much if they vary. Use the highest of these scores to fill in your peak flow diary. If you have any questions about using a peak flow meter, speak to your doctor, nurse or pharmacist. You can also call our helpline.
Hello there. Hello. Got an appointment? Brilliant. Just step in for me so I can close the door. Thank you. So my name is Emma and I will be doing the tests with you today. Before we do anything, I just need to measure your height and weight. And in order to do that, I need you to just take a seat there and slip your shoes off if that's okay. And if you can turn around for me, please. So you're here this morning for a skin prick test, is that correct?
Yes.
Can I just get you to confirm your date of birth, please?
21/09/90.
Perfect. So we'll start by doing a little test, a little blowing test that will measure how inflamed your airways are. This gives us an idea of sort of asthma type symptoms. Then I'll go and get you to wash your arms. I'll pop some tape on your wrists, your forearms, some little aero allergens on there, and then just let the skin know it's there, and we'll wait 15 minutes and we'll make those measurements. Have you used any antihistamines in the last 3 days?
No.
And any hydrocortisone or anything in your...
No.
No, perfect.
I think I'm allergic to wheat. Can I be tested for that?
I'm afraid these are allergens that are found in the atmosphere. They're not food or drink. If you wanted to look for food or drink allergens, you would need to do a blood test or a patch test, which would be on your back, which we don't offer here, I'm afraid.
Okay.
Is that all okay with you?
Yeah, that's
Yeah, brilliant. So we'll just do this little breathing test. So this is quite a simple test. Once I've popped the filter on, I'll get you to gently blow all the way out for me. I'll then get you to take a really big full breath in through the little mouthpiece here, and then blow out at a constant pace. I hand you that. You'll pop your lips tight around that tube, take a big breath in and then blow out. And on this you will see the cloud rise up when you take your big breath in, and then when you blow out I'd like you to keep the cloud in the middle of the screen. If you blow too slow it will fall to the bottom, and if it's too fast the cloud will be at the top of the screen, and we'll just course correct each time and bring the cloud back to the beginning, to the middle. Is that okay? Yeah. So when you're ready, gently blow out, lips tight around the tube, big breath in, and then blow. Slowing it down, speeding it up, that's it, well done. Keep going, speeding it up, well done. Keep that going, really good. Keep that going, keep that going, keep that going, keep that going, keep that going. Nearly there, keep it going, well done you. Excellent, off you pop. Brilliant. So while that does its magic and calculates the inflammation of the airways, I'll get you to go and wash your arms. have another seat for me? Thank you. So that's it. If you just pop your arms up there for me, I'm just going to pop some tape on your arm and then we'll start adding the solutions on.
Do you want both my arms?
No, just the one should be enough. If I do need the second arm, I will let you know. If I get you to just pop your arm over like that, if you can, try and hold it nice and still like that for me, please. And the airway inflammation isn't too high. It's a little high, a little outside of the normal range, but it's just in the mild element. That's what that little pin was.
Yeah.
Just going to add a little bit more tape just to get the bottom of your arm there. So now I'm just going to start putting the solutions on. So I do need you to keep your arm nice and steady for me. I know it can feel a little uncomfortable, but what I don't want to do is have the solutions all wander around your arm. Okay.
So what's in the positive and negative?
So the positive control has histamine, which is your body's natural reaction, a chemical your body naturally produces. And the negative control has saline in it, so it's just a nothingness. If you do react to the saline, we would take any measurement bigger than the saline as a positive reaction. Okay. So now I've just got to go through and very gently start letting the skin know that there's a thing there for it to react to. Okay. An allergen there.
Am I meant to feel anything, or?
You might just feel a gentle little prick, but you shouldn't feel much.
Okay.
We're not trying to hurt you, we're just gently letting the skin know. So that's all of those now pierced, and the skin will know that there's something there to react to. So I'm just going to gently pat those off with your arm. That's it. You can now let your arm move. So you don't
itchy.
Don't itch it.
Okay.
Just resist the itching, and we're just going to sit here now for 15 minutes and wait for any reactions to occur. Okay. Okay, so we're just towards the end of the 15 minutes. So I'm going to put alcohol gel on my hands and then I'll start feeling down your arm to see if there's any reaction. I'm not going to put any gloves on to do that. Is that going to be okay with you?
Yeah, that's fine.
Perfect, thank you. And once I've felt down, I'll then start measuring the size of any reactions. Okay. A lovely positive reaction. You've reacted to birch trees. Tiny reaction to dog. Possible reaction to mixed trees, and then quite a large reaction to grasses. So I'm now just going to measure the size of those reactions. Over the top there. Brilliant, and I just need to try and gauge how much of a red reaction you've got. There's quite a large red wheal around the grass and a big one around there, so about 2 and about 4 centimetres. Brilliant. So I'm now just going to add some hydrocortisone cream to your arm.
Can I take the tape off?
Yep, feel free. I don't want to hurt you. Brilliant. So I'm just going to pop it in places I think you need it, and then I will let you rub it in just because it's really for you to do. So if you rub that cream in, and that cream will just start to take the itch and reduce the reaction down a little bit for you.
Okay. So what are the outcome of this test?
So there's obviously an allergic response there to grass. It might be worth you taking some antihistamines, certainly during the summer periods. And I would say don't sit on grass directly. Always have something separating you from the grass itself. Just the normal common sort of things in that respect. And the results will be formally discussed with you when you see the consultant in clinic.
And come to the latter part of our presentation. Actually, it is asthma is bronchial asthma is not a sole reason for wheezing. In children, actually, we can have different kind of reasons to have wheezing, and bronchial asthma is a clinical diagnosis. And again, it is asthma is not a simple disease. It is actually heterogeneous disease. We can have different conditions and different kind of asthmas, including this bronchial asthma. Inside this bronchial asthma, actually, investigation are used when there is diagnosis is uncertain. Then actually, if there is atypical features, we have to do investigation and see whether there is other diagnosis. Then when there is management is difficult, we have to do investigation and assess further assessment. Then if there is difficult to treat asthma, it is likely to have some other diagnosis rather than bronchial asthma. Then we have to get good clinical evaluation and followed by a good tailor-made investigation to rule out bronchial asthma and rule out other diagnoses in these conditions. Thank you very much.
Let me thank Dr. Ganganath Gunathilaka for that interesting lecture, and thank you all of you for joining us today, and let's meet up in 2 weeks' time.